Well, hello and thank you for joining us today. The Nevada Primary Care Association welcomes you to the following webinar, Hazard and Vulnerability Analysis, What to Know When You Don't Know. Now, before we begin, there are 3 housekeeping items to review. Number 1, this is a live presentation that we will be archiving on our website. Please do not put this call on hold as this presentation might be interrupted by on-hold music. Number 2, please ask questions. Our presenter, Denise Heifel, encourages you to ask questions at any point. And number 3, this webinar is being recorded and will be posted on our website within the coming days. Thank you for your attention to these housekeeping items. It's my pleasure to introduce our presenter, Denise Heifel. She has over 10 years of experience working with FQHCs and community health centers. She graduated from San Jose State University with a degree in nursing. Denise now works for the California Primary Care Association as the Associate Director of Health Center Operations. Her focus is on member services with emphasis in emergency preparedness and compliance. Please join me in welcoming Denise to our discussion.
Hi, everyone. Hi, Bonnie. I didn't get a chance to talk to you beforehand. So.
Hi, Denise. We got a little sidetracked with signing on. Sorry about that.
Oh, that's okay. I was just saying to everyone at the very beginning that this is a pleasure for me to be talking with you. I don't really feel like I'm doing a presentation because it's such an intimate group, and I think as we go along, you can interject and ask your questions and that kind of thing without a lot of fanfare. Just jump in and say what you need. Thank you, Scott, for the lovely introduction. It always makes me think that I got my nursing degree at San Jose State before most of the people on these calls were born. It's a pleasure to be here and helping the Nevada PCA do this presentation. A little bit more of my background, just so that you know. I started out in acute care. Working in a hospital emergency room was my very first job out of school. So I've run the gambit. Implemented my first EHR in the 80s. So I have seen a lot of healthcare evolve over the years, and it's always a challenge, as Gary said before, always a challenge, and more so since I accidentally came into the FQHC world. A friend of mine talked me into going to work for a community health center in Northern California, and I had no idea what I was getting into. But at the same time, I can say it also has become a true passion. You all work so hard in your health centers to keep this going, and that's one of the reasons that I think talking about having an HVA and an updated HVA is so important. You work too hard, and like a lot of you in the rural areas and everything, you're the only game in town. So how do we protect that? How do we prepare to keep our patients, our doors open for our patients in the event of an emergency? So really, I hope that we can answer these 3 questions today. Why would you want an HVA? How do you get one? And what do you do with it? Because a lot of us over the years have HVAs that sit on the shelf, and we don't pay a lot of attention to them. So I think my biggest concern at this point is any health center that is an FQHC was required to prepare an HVA at the time they were a new start. Now, in some cases, that HVA has been sitting on the shelf since that date. And I sometimes have it's hard to communicate sometimes, the fact that your hazard vulnerability changes, just like your business capabilities change. Your focus changes. You have a strategic plan. You have a needs assessment. And you really, an HVA is a needs assessment. So you need to have a strategic plan to keep that HVA viable. You need to build hazard security awareness, knowledge of your community partners, the skills of your community partners, response agencies, other health centers within your organization or in your area, whether they're FQHCs, whether they're community health centers or a freestanding clinic. Your HVA can steer you to those partners, and you can line them up to assist you with anything that you're vulnerable for. Information sharing is really important, to talk with your peers about hazard preparedness and how they're doing things, because we don't want to reinvent the wheel. I do a lot of compliance that I think just leads into emergency preparedness or vice versa. And I think it's really important, and I tell everyone this, don't reinvent the wheel. You have so many resources available through your PCA that you shouldn't be out there having to create these things. They can help you with that. And we all have networks between the PCAs. So if your PCA doesn't have something, maybe we do, or maybe Michigan does, or Florida does. So we can all share those things. And the point I'm trying to make there is you have enough day-to-day to keep your clinics going. Don't try and reinvent the wheel. So I think it's important that we talk about the effects of a disaster. If you're fighting fires, you're not nearly as efficient as you are in preventing them. So it's important to look at that aspect of an HVA. It will actually talk to you about what you need to think about in the future. If we think about our kind of neighbor state in Washington and the mudslide that occurred, and what a disaster that has been for them, and how many people are lost, and trying for that community to recover, hopefully the communities around them are able to support them because they have partnered in planning for all types of emergencies. I'm sure no one plans for something like that. I can't see that you would, given, it didn't seem like it was something that was imminent or that could logically happen. But if you're sitting at the edge of the Sierras, yeah, you have mudslides, and you need to think about that depending on where you are. So I guess my question is, and Scott, I'm going to ask you to help me out here because I'm not quite sure how to do voting on your webinar, and I forgot to ask you about that. Oh. But I guess there's not, I mean, we don't have to vote. People can just say, since there are so few of us. I'm curious as to how many organizations have an HVA. And when I say an HVA, I don't know how old your organizations are, but how many of you have an HVA that's been updated in the last year or two?
Denise, I can help with this. Why don't we start with Gary, and then we'll go to Danny, and then Bonnie.
Okay.
Okay, that would put me first then. We have just gone through the process of getting an HVA assessment. Again, very preliminary. We haven't done anything with it yet from all of our locations. It was a checklist item. We used a template that we accessed, and again, we haven't put it to use yet, but we've started that process. And so we do have an updated one, and my goal is to sit down with everybody, review that, and figure out the next steps.
Okay.
But we obviously have a lot of work to do.
Okay.
Danny, how about you?
We have one. We haven't seen it in a little bit, but we did one probably about a year ago.
Okay.
And then, go ahead.
Oh, we did it for the application for FQHC, but we haven't really looked at it recently.
And that was Bonnie, right?
That was Danny.
Oh, that was Danny. I'm sorry.
But Bonnie's next.
We don't have anything specifically that is considered an HVA, but we do have an emergency awareness program that we just implemented and approved by the board last month that goes over all of the natural disasters, workplace violence, all of the threats that are, I guess, considered norms that we would need to worry about and consider. And that was just implemented, like I said, just at the last board meeting in February.
Okay, it sounds like you guys are all up to date, so that's refreshing because it doesn't happen too terribly often. Even, you know, if your HVA is a year old, it's probably time to dust it off and take a second look at it and decide whether it's robust enough. If you have one site, of course, you don't need anything quite as robust as someone that has 16 sites, but at the same time, you're really assessing the same vulnerabilities, whether or not you have a large health center, you know, with multiple sites, or a small center with just one site. You still need to look at the same items, but if you have multiple sites, you should be assessing each site and not just your administrative organization. Unfortunately, that does happen often. It doesn't sound like it's a big problem for you all, but it can be a problem if we're just assessing that one main site. So if you don't have an HVA, you might want to go ahead and take a look at one of the HVA templates that are available. Really, the kind of state-of-the-art is Kaiser Permanentes, and they are more than willing to share that with everyone, which we appreciate. And they have a great template that can help you analyze each event and decide whether each event includes a business impact, a property impact, a human impact. And for our health centers, a business impact and a human impact a lot of times are very much the same because our business is humans. If we have to close the doors, not because we haven't planned well, not only are we impacting just our patient base, but we're impacting the whole community because our patients have to go somewhere. And so that brings in the property issues. If you have a hazard vulnerability for your property, how do you try and mitigate that? So it allows you, the HVA allows you to prioritize your vulnerabilities and to actually have something in writing that you can pull off the shelf in the case of an emergency and have some documentation in place for following through on that if it ever happens. As we know, wildfires are pretty common, and if you haven't planned for that, it's like, how do you do that? What's the probability it's going to happen at your health center? What's the human impact going to be? What's the business impact? Are your internal resources secure, or are they weak? Same thing with external resources, partnering with your counties and your local city agencies and your state, and of course your PCA, can certainly help secure your external resources and make them more a viable part of your day-to-day. Because if something happens in your health center, your internal resources for that hazard might not be complete. And so you need someone to partner with. So I don't know if any of you have available either a clinic hazard and vulnerability analysis or the Kaiser Permanente Health Center Hazard and Vulnerability analysis. But let's talk about types of emergencies. What do you need to plan for in an HVA? Some of the biggest issues that, and correct me if I'm wrong, or throw in the ones that affect you the most, but I think for a lot of your health centers, fire possibly, wildfire or urban fire, hazmat. When I was doing some research, it looks like you guys have your fair share of hazmat teams in place, but you also have a lot of areas in your state where hazmat issues could be a problem from transportation of this type of waste. Earthquakes are pretty common in Nevada, not that they're big ones, but they're, in most cases, they're still there. They're still something that you need to think about in your planning. What's the probability of a flood in your area? Are most of you prone to flooding or flash flooding? Isn't the Carson Valley fairly prone to flash flooding? That would be something that I think you might need to rate higher on your probability list and plan for possibly bringing patients from another area into your health center. What other vulnerabilities do you all have? Anybody want to jump in?
Well, I'll make one comment. With some of our locations, we could have some concerns with a very severe mining type of accident.
Okay, yeah.
Just because of where we're located in some of our locations.
Mm-hmm. And does your health center plan for that in their HVA?
Not yet.
Not yet, yeah.
It was captured. It was captured as an item, but we haven't really. That's the next step that we hope to take.
And I think that's a good point. I think that was kind of the point I was trying to get to, is capturing these things is very important, because you can't plan for them if you don't know they're a problem, and planning for each of your sites. It's very important that when you're putting together your HVA, that you are tapping all areas of your health center, not just your facilities, not just your emergency preparedness, not just your clinical, not just your administrative, but you need to bring your IT people in. You need to bring in health information people. all of those pieces are very important because without all of those pieces, it's kind of like your quality assurance, quality improvement program. Without all of those pieces, you're not going to capture all the types of hazards that you possibly could run into. One of the big things that I see that doesn't get addressed often enough is information systems failure. That is such a critical part of our health centers. All of you have electronic records of some form, I'm assuming. I didn't ask. Do you all have? Does anybody not have electronic health records? Okay. If you have a flood, if you have a fire, if you have an earthquake, all of those things can severely, just a common power outage, can severely impact your health center and how they do business. You know, if you don't have your electronic records, then how do you continue to do business? And, you know, in the case of a mining accident, you know, you may very well have patients that are not your patients because of the proximity of your health center. So how do you plan for that? And contingency plans with transport. You might be able to triage, but somehow you're going to need to transport to a local acute care facility. Although 82% of all injuries in any kind of an emergency can be treated as on an outpatient basis. And this is one of the things that we try and make sure that everyone around us knows about our health centers, because we are such a critical part of any kind of a community emergency response. So your HVA needs to address that too. You need to plan for that mining accident. Now, if that mining accident probability is a 1 on a list of 1 to 5, you're probably not going to give it as much of a look, but you should, because you need to not only look at the probability factor, but you need to look at the human impact and grade that, and the business impact and grade that. And the same thing with internal and external resources and grade those. Because what might be a low probability with high human, business, internal, and external impact, if you're rating those things from 1 through 5, and the probability is a 1, but the impacts are all 5, that may be higher on your list. Say it scores a total of 21 points. That may be higher on your list than, for instance, a flood, and I'm saying flood, not flash flood, but a flood being a 4 on your list, the probability, but your health center is pretty well isolated from actual floodwater. So your business impact might be a 1. Your internal resources are good. Your community resources are good for that. The human impact may be a little higher. But so you've looked at all of the analysis, and you've come up with, even though the flood is, say, a 4 out of 5 in probability, the total impact is a 10. Whereas that fire or mining accident, that's a 1, could also total a 21. So my point is that you really need to look at the overall analysis of each type of emergency. So if you don't have an HVA, but you have an emergency operating plan or a continuity of operations plan, and it doesn't include an HVA, you may be planning for things and putting a lot of your time and effort into a type of emergency that should be lower down the list. That's where the HVA comes in, to help you truly assess what the overall impact is going to be on your health center and on your community, so that then you can focus your energies, because I know you all are completely staffed and you have lots of hours to put your feet up on the desk, but you wouldn't want to interrupt nap time, so you don't want to be planning for something you don't need to plan for. But seriously, we all know that you all wear 5 different hats, and trying to get the time to plan for all of this is not easy. So focus on those items that truly are going to be the most impactful on your health center. So what type of emergencies have you encountered? Have your health centers had to go through, and how did you handle those? Did you have planning for them?
Can we go ahead and ask Bonnie to comment on that?
You can. We haven't had any emergencies that I could that we've had to deal with as of yet, at least not to my knowledge in the 8 years that I've been here. So I don't know how to answer that. We do have, you know, a few things in place. One of our biggest focuses right now is the workplace violence, and we have a program in place on how to handle that, and we're going to start active training the first week of April. So that we can be prepared in case we ever have an active shooter or any type of active violence on any of our work locations. So we definitely have the preparation for many things. We've been fortunate not to have to implement as of yet.
Great.
How about Northern Nevada Hopes? Danny, how about you guys?
Yeah, this is Glenn, facility manager. And we've implicated a lot of, well, since I've been here, we've implicated a lot of plans for which we have fire, flood, and then earthquake potential here. So we put into play where everybody, if something does happen, each department knows where to go, who's the head in that department, do a number count, assess what it is. We also have a bomb threat in place, violent in place. So, I mean, we've implicated a lot of stuff, just not everything yet.
And we're working on, again, like Bonnie was saying, we're also working on a workplace violence policy and procedure. So we have something in place, but we're still fine-tuning it.
Great, thanks, guys. Denise, if I may, I'm going to change the presenter to myself quickly because I want to show folks what you're looking at when you're talking about ranking stuff. So can everybody see my screen?
I can.
Yep, I can see it.
Good, okay. So Denise, since you've got a lot more experience in filling this out, can you talk a little bit about how health centers could use this location by location to come up with some risks and identify how they should pursue emergency preparedness efforts?
Sure. Like we've talked about a little bit, is that the Kaiser has this excellent form that you can get as robust as you'd like or not. One of the forms that I use, and that's why I was saying 1 through 5, is because there's another tool that I use that does 1 through 5. It's I like the 1 through 5 just because I don't generally know the health center that well if I'm going in and helping them do an HVA. So going in and doing that, I usually will glean more if I talk to the health center about rating it 1 through 5. But I think these are fairly much self-explanatory. For instance, mass casualty incident trauma right from the very get-go. You know, how much would that be? I mean, if you had a mining accident, I'm going to just go back to Gary's because it was something I have to admit. I must truly be a California girl. I didn't even think about that. But if you had a mining accident, the probability is probably low. When was the last time you had a mining accident? You kind of have to look at all those things. But this would be a mass casualty trauma. The human impact, you have to look at death, injury. How many people are you going to have come in? Is it going to be low? Is it going to be 3 people? Or is it going to be 50? You need to look at, property impact really from your own health center perspective. Obviously with a mining accident, I wouldn't think that it's going to impact your health center physically. So that would be probably a 0 or a 1. You could look at property impact to the community, but generally the easiest focus is on your health center. How's it going to impact? Are you going to have broken windows, you know, whatever the case may be. And then your business impact. Is that mining accident going to cause a power outage? Is it going, any kind of utility outage? Weigh those things. Probably not so much. So can you pre-plan for this? How well have you done pre-planning for this? Do you have resources to treat a number of trauma victims? Are you the closest game in town? Are you going to be on the triage line before the ambulance gets there? Are you closer facility-wise than your closest hospital? Have you planned for your staff to actually go on site to do what can be done in this trauma situation? So you need to think about how you're going to plan for this. Now, granted, your plan for this event could be, we're going to not take any trauma, we're going to close our doors, whatever the case may be. It's still a plan. If your plan is to have everybody diverted to the closest hospital, no matter what their injury is, it's still a plan. It's something you can do that you can let your partners know, let your community know, so that they know how they're to react in that situation. Internal response. If you choose to get involved in this, are you going to see patients in your facility? What is the resource? How are you going to see your day-to-day patients and still be involved with taking care of the trauma patients? You need to weigh that. If you have a health center that has an urgent care, then you probably could divert your urgent care patients into your family practice area and see trauma patients in your urgent care. Is that time effective for you? Is it the best use of your resources for the community? You have to weigh those things. That's why the HVA is such a great tool, because you make that decision. You partner with the community in that you share your plan with them. But you have made the plan. You make the best patient decisions. you make the best provider decisions, and you make the best business decisions for your own health center. And then external response. You need to plan if this is going to impact your facility. Do you have external response? Do you have a plan with your county health department for resource requesting if you choose to treat these trauma patients, for example? Do you have a plan with your ambulance companies and your EMS? Where are they going to pick the patients up if they need to be transferred? Where are they going to drop them off if they're bringing them to your health center? These are the kind of things that that's why I said you need to look at all of these areas and make a decision on whether this is something you need to put a lot of time into. Because that mining accident may be a low probability, but the impact may be huge, or it may be a high probability and the impact is not going to be that big. So you need to weigh that and decide how much planning and preparation you're going to put into each of these areas. On the other hand, you have something like infant abduction. Well, today, you know, this is a hospital piece, but if you have a PEDS department, it's probably at least a moderate probability. And yes, you are a family practice organization, and you probably do. That is one of your priorities. It would be to handle any kind of a child or infant abduction. So this this form will take you through many, many, many different places. You have, I guess I'm not doing a good job of controlling here.
Oh yeah, I've got the mouse and so on, but as you guys can see, there's some. Do you want me to give you control? Hold on one second.
No, you don't have to give it back to me. I'm good.
Okay. There are some tabs that are at the bottom of the spreadsheet which comes up with a few different ways of categorizing and so on. But Denise, if I'm correct, what our members can do is we can send them a copy of this toolkit that Kaiser Permanente developed, and they should be able to come up with a report card for each location, and then based on that information, they can come up with some strategic direction.
Exactly. Exactly. That is the key, is go through, see what's pertinent to your organization, go through the entire assessment and analysis, and then sit down and make a decision as to what are your top priorities. And those should be the things that your EOP focuses on, and your training and your drilling focus on, and the things that you take and share with your partners. Having a hazard vulnerability assessment is great if you have a partner hospital too, because then they aren't guessing that the community health center 3 blocks away is going to do this, or they're not going to do anything, or they don't remember you're there. But if you communicate with their emergency staff, which they're required to have, if they're Joint Commission accredited, they are required to have an emergency preparedness staff. So that's the person, when you finish this, it's one of those, what the heck do I do with it now that I have one plans? You know, what is the usefulness? Well, it's that partnering. It's weighing everything. It's getting all your staff trained in, say, those top 5 items that you feel will probably impact your health center.
That's great, Denise. Bonnie and I had an opportunity to talk about some emergency preparedness items yesterday. And Bonnie, you were talking about the dental van? Could you give some information to that to Denise, and maybe we can talk about how we'd utilize this toolkit?
Sure. So we have 2 mobile dental vans that are utilized, as well as a mobile WIC van. And they go to different school sites and other places where the dental vans see children. One's a restorative van and one's a sealant van. And then, of course, WIC is the women, infant, and children, so they're seeing, that population. And one of our concerns when we have our safety committee meetings is, in the event of an emergency, obviously if one part of the van catches on fire, they know what their exit strategy is for that. Kind of different concerns are with the workplace violence being such a high priority at this point for all of us. Is what do we tell our staff to do in the event that someone comes on there who's angry and they really don't have any other way out? So we've kind of talked in depth about what may or may not be able to happen. I don't know, just those are kind of those places that only have one exit. You could have multiple staff and clients on there at any given time. And it's just kind of, we think it's important to keep focused on what we may be able to do for them.
Yeah, it's a good point, Bonnie, because that is, other than law enforcement, healthcare is the second leading institution, for lack of a better word, as far as workplace violence incidents go. Of course, we have, we bring forth a lot of emotion in our clients that the banking industry doesn't, or the furniture store down the street doesn't. But you have so many ethnic differences, and you have your language barriers, which can be a huge problem. And I think you're right. We all need to focus on workplace violence. I know one of the things that I am struggling with, and that I think I have finally found some training in, is not just basic workplace violence, but de-escalation.
Right. Right, and we've had some training on de-escalation through our psychology department, but unfortunately not everybody's equipped to de-escalate a situation, and on the mobile vans they don't have the option to just call a supervisor to the front counter. So I think those are, and again, we've been real fortunate. We have not had any problems, but as we move forward with this, we want to make sure that we're benefiting the staff that works on those vans and not make them feel like they're not as important as somebody who works in the clinical area.
Sure, and it is a much more dangerous place to work. The thing that I have seen in most of the mobile clinics, and I don't know if yours has this or not, but a lot of the newer ones are now coming with a panic button that's a wireless panic button that is attached to, if you're outside of a school, that you have a connection to the administrative office, so that they would know that there was an incident in your van. If you're parked outside of homeless shelter, their administrative office, you can actually program these wireless into the area where you are, where you're seeing patients on any given day. So that, I know, has become kind of a state-of-the-art thing to do with some of the newer vans, and I'm certain that it can be installed in the older vans too. It's just that it's state-of-the-art in the new or refurbished mobile vans. So that, and you're right. I mean, there's very little other than de-escalation and something like a panic button that
Right.
you can do in that because you're in such cramped quarters. There's not a lot of, you're probably not going to jump through the window, but if you had to, it probably would be an okay thing to practice. The other thing that we see in anything that involves your PEDS patients is there again you always have that child abduction issue. What a great place to just, that child's confined, and whoever wants that child, and in most cases, of course, we all know it's in most cases family member or someone known to them, they know they're there, and they just snag them. It's very difficult for you then to follow up on that. I mean, what do you do in a situation like that? It's not like a school where, it might be fenced off or anything like that. You're open and you're vulnerable to that kind of thing. So, in that case, there again, the panic button works, that kind of thing. In that case, de-escalation doesn't work. I know that in the hospitals, they try to talk about that kind of thing, but once someone snags a child, they snag a child. And there's no amount of conversation that's going to talk them out of it. So, yeah, it's a difficult situation, but my recommendation would be the panic buttons. Now, having had some EHR, IT background, and having programmed some of these things, you really need, if you're going to do that, you really need to have somebody on staff that spends quite a bit of time with that particular part of your IT. Because I will tell you right from the very get-go, I know for a fact they're not easy to program. Because they're moving all the time. It's a moving target. So it can be tough to do, but I think it's well worth the time and effort and the investment if you possibly can.
Okay. We'll take that into advisement. Thank you.
And Denise, that's great information. I know that Nevada Health Centers has a mammo van. Gary, have you guys had any of this discussion on how do you protect the van?
No, I made some notes, though.
Oh.
No, that hasn't. I like the wireless panic button and things like that. Because we also have a dental van which only sees PEDS.
Yeah, and there again, it's that PEDS population that's so vulnerable. I've never heard of any kind of a situation on a van like your mammo van or anything like that. But that doesn't mean it's not going to happen. But we do hear about it with PEDS organizations all the time. So.
Well, there was also a question from Northern Nevada Hopes as far as what would you do if your pharmacy was not operational? How would you deliver medication to your patients? And Denise, what I think we should do is use this toolkit that's on the screen just to talk about it, and then I'll change you back to the presenter after you've addressed that one.
Well, okay, I kind of liked you being the presenter, but whatever works. As far as the pharmacy can't be accessed, I guess my question is, why can't the pharmacy be accessed? Because that would be, I mean, it would probably be a couple of different scenarios. One, the pharmacy is that you've got a power outage and nobody's in the pharmacy and you have electronic access only to the pharmacy. Or I was just wondering kind of if I could get more information on the scenario.
I don't think there's anything specific, just like a natural disaster, something big like that where the pharmacy just couldn't be accessed.
Okay. I know that a lot of partnerships with pharmacies you're talking a pharmacy in your health center, correct?
Right.
Yeah. A lot of pharmacies, a lot of health centers that have pharmacies will have a reciprocal agreement with a freestanding pharmacy in the community or your hospital pharmacies. If you have a hospital in the near proximity, to be able to get those medications on an emergency basis to your patients. I mean, granted, we aren't talking 3 months out. These are really, stopgap kind of things until you can procure additional pharmaceutical supplies and work with a partner then. So if you had a free, the health center that I worked in had a pharmacy, but we also had an agreement with the hospital up the street so that if there was a situation where we couldn't access our pharmacy or they couldn't access theirs, that we would basically move into the other pharmacy. And they would supply emergency meds to our patients and vice versa. And also that would be part of a business associates agreement with your pharmaceutical houses so that they were your second delivery spot, so that they were actually listed on our agreement. At the time, it wasn't a true BAA because it's been a few years. But there was a written agreement with this is our second drop-off spot, so that those things were in place ahead of time.
Great.
The problem that I will tell you, and I'm sure you've thought of this too, is how mobile are your patients? Because if they have to go 2 or 3 miles to the nearest pharmacy, that's going to be an issue for them. But other than that, because you can't set up a pharmacy, there's no way licensing is going to let you set up a pharmacy in a triage tent out in a parking lot.
Yeah.
I mean, you can do trauma in the parking lot, but they're not going to let you be storing meds on the parking lot. So that's the only thing that you can do is go into a licensed pharmacy.
Right. I think what we really wanted to know was if our patients were unable to access our pharmacy, how we would go about getting their medications. So I think you're about the business agreement and, doing that and having our supplier have a second delivery site nearby us, that was really helpful.
Good. Fortunately, we never had to test it in our health center, but the agreement was there.
Right. Sounds good.
Okay, well, good. Denise, I'm going to go ahead and change you back to the presenter.
Okie dokie.
And I think you just had to show your screen, and we should be back off to the races again.
Are we there?
You had to show your screen.
Oh, I thought I said. It's not letting me. I'm going to give you the mouse. We're going to give back to me again and say there. Can you go ahead and give it back to me? It didn't register.
Sure, I'll try again in just a second. Okay.
Let's see. There we go. That should do it.
Yep, we're back.
Yep.
Can everybody see Denise's screen?
Yes.
Yay. Okay.
Okay. Okay, good. So, weighing the probability of an event, we talked about that. I think one of the things that you really have to look at is the potential frequency. If it's going to happen, if you figure it's going to happen once every 50 years, then you're not going to want to, like we said, give it as much of your time. Remember that if you have a few different health centers, that their geographic area is very different, and what might be an earthquake potential in one is not in the other, but you also can use your hazard vulnerability assessment to plan to support each other so that you can support within your organization. As an example, you have a health center that you have 2 health centers that are 15 miles away apart. Or you have a partner that's not even part of your organization and you're 15 miles apart. Remember that when you're planning for that wildfire, that one health center that must close and evacuate, even if they're not going to send their patients to your health center, or your partner is not going to send them to you, another thing that you might look at is that impact of the fact that you have meds that need refrigeration and now you need to evacuate. You have lots of vaccines that have to be temperature controlled. Do you have a contingency plan for storing those? One of the places that you can go to for that is to your county public health. Your health department, if they don't have the capability, will certainly be able to partner with you to find someone that you can have an agreement with. Because you might only be out of your health center a day or two, which is very impactful, but nonetheless, you may only be out a day or two. But when you go back, if you've lost all of your vaccines and you've lost all of your temperature-controlled medications, you're going to be out of business in many areas for a lot longer than a day or two. And that's where we have to talk about business continuity planning. You know, your HVA, like we said at the very beginning, is a needs assessment. And then you need to plan from that. And planning from that also takes you to a business continuity plan. So this is really the cornerstone for everything that you do as far as planning in your health center goes. You know, your EOP, your continuity of operations plan, all of those things should come off of your HVA, because otherwise you're planning for general things and not things that you should really be focusing your time on. I can't stress enough, don't take your precious man hours to plan for everything. You have to plan for all of the things that are likely to happen to you. And we talked a little bit about community awareness and how you can engage with your community partners. If your community is very tight-knit, you're probably already doing that. But in many cases, you find, and this, I use California as an example because I'm a California girl, but I also interact with people all over the country, and we all have the same problem. The community health center what? Unless you're the only game in town, a lot of times the rest of the emergency planning partners in your area may not even know you're there. I know of a health center that had been in the same area for 20 years. They were interactive with EMS, their hospital partnership people, their county mental health, their county public health, and yet in planning for a drill, the coroner's office was there, and the coroner had never even heard of them. So had there been some kind of an emergency, and Had they needed the coroner's office, as much as we don't want to think that happens, it does happen at our health centers. People will actually bring their dying family member to the health center. In this case, the coroner's office didn't even know where they were. They didn't know they existed. So I think sometimes we have to think down into the weeds, and we have to think about making those partners aware. Be sure that you're interacting with all the emergency preparedness folks in your community. And that does include the coroner's office. You wouldn't want to have to interact with them often, but when you need them, it would be really nice for them to know you're there. So planning, planning is everything. We talked a little bit about how often to review your HVA, and there was the comment that you had reviewed about a year ago, and that's actually about the right time frame. Every year or two, of course, best practice is annually, but realistically, if you can review it every 2 years, you're great. But just don't forget it's there on the shelf, and it needs to be taken out and dusted off. You need to remember that what you looked at last year may have changed this year. And that sounds silly because in a lot of cases an HVA is something that you're looking at your geographic area. Well, if you haven't looked at your HVA for 5 years and you just had a dam built 20 miles up the road in that, in that canyon, what may not have had a huge flood risk 5 years ago is now in the direct path of flooding. And what are you going to do? So you need to remember to look at those things and not just run over the HVA and go, yeah, all looks good. You need to give it a little bit of thought. If you get your safety team together or your facilities team together, you're all going to see something different, so that becomes really important. So one of the things that we talk about is what are your next steps. It sounds to me like you all have your HVAs in place, but you haven't necessarily moved forward with them. When you take that next step and take those vulnerabilities and start planning to address them, then you need to look at, do you need a continuity of operations plan? That's one of your next steps, because you can't, if the power goes out, that's a big crisis for a health center. A lot of times you can't access much of anything because everything's key carded anymore, and a lot of that's electric. Your EHR is electric. In your continuity of operations plan, if nowhere else, you would have your downtime plan. How long are you going to wait when something simple happens, like the power goes out? Because that's all. That's a vulnerability for all of us, rural or urban, mountains to the deserts. It doesn't matter. It's still a vulnerability. What are you going to do? Are you going to try and stay open? Are you going to close your doors? How is your health center set up? You need to look at that. Do you have natural light? Can you go ahead and do that PEDS well child check if you don't have power instead of shoving everybody out the door? Those of you who have dental, more than likely, you're not going to stay open, because if you need electricity for that water in those operatories, you're not going to stay open. You don't have power for a drill unless you have a battery backup, but I've not seen that. That would probably be a great EP thing to come up with. How do you finish that root canal now that the power went out? But you need to look at how long are you going to try and stay open. If the power goes out, do you immediately stop seeing patients because your EHR went down? Or do you have a time frame for when you move on to your downtime plan? So all these things have to be taken into consideration as part of your next steps. And as far as not reinventing the wheel, your PCA is there to support you. We all like to, in the PCAs, get as involved as we can in helping you to do this without disrupting you so much and pulling from other people. I mean, Scott is always more than welcome to email me and say, hey, do you have this? One of my health centers is looking for that. You know, we're not very proprietary in this business. And so your PCA can support you as you take those steps. Another way to enhance that is for you to get together as an emergency preparedness peer network. Put topics out there that are of interest to you that you want to address. Meet, I know you're all spread out just like we are in California, but you can meet via webinar. You can meet via teleconference. Meet monthly, meet bi-monthly, meet quarterly, and share those issues and get that peer feedback. It's a huge benefit. I know that our calls are well attended, and we do get a lot of questions about, okay, so now the feds are requiring this. What are we going to do to meet that? The new CMS rule that's still in draft, but we hope it'll never happen, but we know it will, where every organization that that bills for any Medicare services is going to be required to have an emergency operating plan. When that comes into effect, we don't want everybody trying to reinvent the wheel. There's a lot of folks out there that have EOPs right now that we could all turn around and share and get this taken care of before it becomes a big misstep for our health centers. You know, there's so many things that you can share as a peer network. What do you do when you're trying to announce that there's a problem in your health center? Where do you get those codes? Do you use codes? Do you make up your own? Do you use the ones that your public health department uses, which are undoubtedly the ones from the hospital association, so that you're all on the same page, so that you can go from health center to health center and know, just like the hospitals do, exactly what those things mean? So I think that the first step is getting your vulnerabilities down on paper and making a conscious decision that you're going to take those next steps and move forward. And then joining with your PCA and your other health sister or brother health centers to get those organizations so that you're all functioning on the same page, so you're not having to reinvent the wheel.
And
So,
Denise, it's Scott. I think that you did a great job in plugging what we've been thinking about for a while, which is trying to come up with an emergency preparedness peer group that's made up of our membership. And a great example that I can think of at the moment is we were talking about the dental van. and how to protect that and so on for Community Health Alliance. And then Gary was saying, well, you know, we've got that mammo van too, and that might be something that we need to consider. So we wanted to provide for you guys a presentation today that wasn't so much us lecturing, but more us interacting with you guys. And if the folks that are on this presentation today have an interest in forming an emergency preparedness discussion group, I think it would be a great benefit to all, and we could talk about the frequency if we want to do that monthly, every 2 months, or quarterly. But I'll let Denise wrap it up, but if you guys have an interest, I'd love to start spurring that activity.
Great. I think it's I truly do think it's a great thing. I did emergency preparedness in the health center for several years before I came to CPCA, and I had come from emergency preparedness in a hospital setting, but gosh, there was nothing like interacting with the rest of the California health centers and finding out what they were doing, because as with all of you, you have not only the emergency preparedness hat, but probably 4 other ones as well. So that being said, I'm done lecturing you about HVAs, and I'm hoping that if you have any questions or anything, we can address those now, or if there are situations that you want to talk about. We still have about 15 minutes that I wanted to leave it open for questions at that point, and we're talking through scenarios that are issues for you. Well, it sounds to me like you're becoming a very quiet group now.
It's the end of the lunch hour.
But I don't have any questions at this time.
Okay. Can we just get
I don't have any questions either. So.
Could we just get a voice off? Gary, you indicated interest in participating in an emergency preparedness group. Are you still willing and able to participate?
Yes.
Okay. Danny, would you guys be willing to participate?
Yeah, we think so.
Okay. And then, Bonnie, how about you guys?
Absolutely.
Good. Okay, so when we wrap up with our presentation today, I will send out a meeting request through Doodle so that we can figure out a good date and time for us to gather next. But again, this has been a very interactive discussion, and we thank everybody for participating with us today. I'm going to throw it back to Denise to see if we've got any other questions from the group, and then perhaps she can close up for us.
Okay. If there aren't any other questions from the group, and it doesn't sound like there are, I would just like very much to thank you for joining us today. It's always a pleasure to talk with a new group of people that I haven't had a chance to talk with before. It is extremely nice to be able to actually interact with the attendees on the webinar. So again, I'd like to thank you, and if you have any questions for me after the webinar is over, if there's anything I can do for you, please don't hesitate to get a hold of Scott. He knows where I am. He knows how to get a hold of me, and we try to talk fairly frequently so that we know what's going on your side of the mountains, and you know what's going on our side. So again, it was my pleasure, and I thank you very much for attending and for having me speak with you today.
Great, thanks Denise. And I'm going to go ahead and paste a survey into the chat box. If you guys could just take a few minutes and fill that out now that we've got your time, it would be awesome. Your input really helps us produce trainings that are meaningful for our membership, which is you guys. So just wanted to thank all for attending today, and thanks to Denise for a great presentation.
Thank you.
Thank you, Denise. Thank you.
Thanks. Thank you.